All right, so pec minor is, of course, deep to pec major. And it's, it looks like a much smaller muscle, which it is, but it's very powerful for a small looking muscle. Starting with the origin, it's on the third, fourth, and fifth ribs. So again, we're always thinking we're thinking, okay, well, this one attaches on the scapula and the ribs. Which side moves more? Which side moves less, right? So that cuts down on your memorization for which was origin, which was insertion. Well, the scapula is going to move more than the ribs. So the rib side is our origin, less mobile. Our scapula side is our more mobile. So we're on our third, our fourth, our fifth ribs. And then inserts on the medial surface of the coracoid process of the scapula. Or a lot of times people just say coracoid process of the scapula. And so again, that's that anterior projection in the front of a scapula, I guess Latin or Greek, I forget which, it means crow's beak, or it is derived from crow's beak. And anyway, that part that sticks up front, which is palpable, but depending on the person's shoulder, their position, sometimes it sticks up more or less. If you rotate and roll and move your shoulder and feel inferior to your clavicle out on the lateral side with like 3 fingers together flat, you can feel it come out and in. Now, there's some nerves that travel under there. So always be aware if your client is, tells you about numbness, tingling, shooting pain, or a lot of times they don't really want to speak up, or they just assume you know what you're doing and they won't speak up. So you have to let them know. What you might just see them kind of moving their hand. And so then you want to ask them, because it's probably like getting numb and tingling if you're pushing in that area. Mm-hmm. You're probably pushing on the brachial plexus. And if you move, everything will be all okay, but you don't want to just keep pressing on a nerve that you're impinging. Does that bring up questions? All right, so then these fibers go down, like 3 angled down, like an angle down and in, deep to pecs, right, which are big, crossing over. And the actions are to depress the scapula, abduct the scapula, so bringing it forward and downwardly rotate the scapula. Now, your textbook, in this case, will say scapulothoracic joint, but just to keep in mind that where the scapula interfaces with the thorax or ribs is not a true joint. But insofar as talking about what are the motions of the scapula, it's still talked about like scapulothoracic joint. But there's no joint capsule, there's no bursa, it's not really a joint, but that's the movement around which we're discussing. You bet. With the scapula fix, also elevate the thorax during inhalation. So another one of those to keep in mind with people doing like a lot of like stressed out upper chest breathing. And then as far as massaging it, you're going to have a lot of clients who they're pec minors, again, with their shoulders brought forward and all that. Their pec minors are short and tight. So you're going to want to work your pec minor if you have permission. We'll teach you this in the lab, of course, but a couple of things is that if you try to go directly through pec major, it's very difficult to isolate, like when are you exactly on pec minor. You can definitely press through the tissue of pec major and maybe you will be on pec minor. But if we want to really isolate to make sure that we're actually on pec minor, we can go around that free border of pec major around the lateral side, pressing medially towards the ribs to really isolate it. Now, again, these deeper muscles, 9 times out of 10, they're very tender on people. So we just want to warm things up and go slowly. We don't ever want to like go in there quickly because it will be very tender on people. To some extent, you can certainly isolate it on the coracoid process as well, but it's very tendinous right there. And I find that, going around to where it under pec major is even more effective. Questions?